Hi, I am Peter Gloviczki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery. I am pleased to share with you the highlights of the very best papers we have in the November issue of the JVS. The Editor's Choice article is entitled Long-Term Survival and Secondary Procedures After Open or Endovascular Repair of Abdominal Aortic Aneurysms, authored by Dr. Van Schaik and colleagues from the DREAM trial participants from 5 centers in the Netherlands. The authors present the 12-year results of the randomized controlled Dutch DREAM trial, headed by Jan Blankenstein, that randomized 178 patients to open and 173 to endovascular aortic aneurysm repair. 12 years after randomization, the cumulative overall survival rates were 42.2% for open and 38.5% for endovascular repair, for a difference of 3.7 percentage points that was statistically not significant. Freedom from reintervention was 78.9% for open repair, significantly higher than the 62.2% for endovascular repair. Finally, reintervention rate and reintervention-free survival was not different between the two groups. No differences were observed in causes of death, and cardiovascular and malignant diseases accounted for the majority of death during follow-up. The authors concluded that at 12 years, EVAR failed to improve survival, but it was not inferior to open repair. EVAR patients, however, required more reinterventions than those who had open repair. Continued follow-up after EVAR is recommended because of concerns of durability and the need for reinterventions. Our CMA article in November is entitled Comparison of Percutaneous versus Open Femoral Cut-Down Access for Endovascular Repair of Ruptured Abdominal Aortic Aneurysms, authored by Samuel Chen and colleagues from the University of California, Irvine Medical Center. This is a retrospective analysis of prospectively collected data from the American College of Surgeons National Surgical Quality Improvement Program Targeted Vascular Database. Percutaneous access for EVAR to treat ruptured abdominal aortic aneurysm has been used with increasing frequency. Its use increased from 14% in 2011 to 32% in 2014. In this study, 30-day mortality was significantly higher when percutaneous access was used for EVAR compared to the traditional femoral cut-down. But as experience accumulated, this difference in the last 2 years of the study, in 2013 and 2014, was no more significant. The difference between the two groups was not significant in operating time, wound complications, or length of hospital stay. The authors suggest using a percutaneous access for endovascular repair of ruptured abdominal aortic aneurysms as an evolving access of choice. Selection criteria for percutaneous access, however, in this paper is still not well defined. The next paper that you can download free of charge this month was written by Dr. Saleh and colleagues from Ain Shams University and Al Demirdash Hospital in Cairo, Egypt. This is a prospective randomized trial of long-term hemodialysis catheter removal versus guide wire exchange to treat catheter-related bloodstream infection. Now, this RCT analyzed data of 678 patients with long-term hemodialysis catheters and found that infection-free survival was not different between treatment groups, and exchange of the infected catheter over a guide wire with a new catheter 2 to 3 days after antibiotic therapy was as effective as catheter removal and delayed insertion 3 to 10 days later. The authors recommend us using their protocol for management of catheter-related bloodborne infection, and this includes catheter removal and delayed insertion only in patients with severe infection, and guide wire exchange to new catheter in all other patients, because this saves the patient from an additional procedure and the associated cost. The final paper we strongly recommend you to read is entitled "Surgeon, Not Institution Case Volume is Associated with Limb Outcomes After Lower Extremity Bypass for Critical Limb Ischemia in the Vascular Quality Initiative." This was written by Dr. Lily Johnston and colleagues from the University of Virginia in Charlottesville. Now, this is a retrospective analysis of the prospectively collected Vascular Quality Initiative data that included 14,678 lower extremity bypass operations performed by 587 surgeons. This study revealed that annual surgeon volume, but not institutional volume, was associated with improved primary patency, longer amputation-free survival, and fewer major adverse limb events. Result of this study suggests that maintaining adequate surgeon volume is essential to achieve good outcomes after lower extremity bypass procedures. Now, these were our selections from the November issue. You can download each of these articles free this month. To access them, please visit us on www.jvasksurg.org. Enjoy reading all 3 JVS journals and let us know what we can do to make them better to satisfy all your professional needs. See you next time for the highlights of the 2018 January issue of the Journal of Vascular Surgery.